So this is the continuation of Chapter 5, Pregnancy Complicated by Medical Conditions. The first condition we're going to talk about is diabetes mellitus. There are several different types of diabetes. So the first distinction we're going to make is if the patient had diabetes prior to pregnancy. Type 1 is a pathologic disorder, as we've talked about in previous classes, where the islet cells in the pancreas are destroyed for some reason. Sometimes it's virally related, but this is an autoimmune disease in which the body attacks itself. Type 2 is insulin resistance. There's also a condition called pregestational diabetes mellitus, and then gestational diabetes, which we had talked about earlier in this presentation. There is noted in gestational diabetes to be glucose intolerance with the onset of pregnancy. And in true gestational diabetes, glucose usually returns to normal levels by 6 weeks postpartum. So remember with diabetes that it is a disorder in which inadequate insulin is available in order to move glucose from the blood into the cells. And it can occur for a variety of different reasons. It depends a little bit on which type of diabetes you're talking about. But primarily it's an issue with no insulin being produced or less than adequate insulin being produced. Therefore, the body decides to metabolize protein and fat for energy, and ketoacidosis can result. So in terms of pregnancy and glucose metabolism, hormones such as estrogen and progesterone and insulinase and enzyme and increased prolactin levels have the following effects. They increase the resistance of the cells to insulin, meaning that the cells don't respond as well to insulin that is present in the bloodstream. And also there's an increased speed of the breakdown of insulin. If a woman can't increase her insulin production, which is what many people can do during pregnancy, then there will be periods of hyperglycemia. Because the fetus is always drawing glucose from the mother, the mom will end up experiencing hypoglycemia between meals and during the night. As I mentioned in the previous presentation, that's why it's so important in gestational diabetes for the mom to eat 3 regular meals and also 3 snacks. And particularly a bedtime snack is important to prevent the nighttime hypoglycemia. During the 2nd and 3rd trimesters, the fetus is at risk for organ damage because of the hyperglycemia. Fetal tissue has an increased tissue resistance to the maternal insulin action. Pregestational diabetes is a major risk for congenital anomalies to occur, and it's typically related to maternal hyperglycemia during the embryonic period. Factors that are linked to gestational diabetes: maternal obesity, a large infant, maternal age older than 25, previous unexplained stillbirth, history of gestational diabetes in a previous pregnancy, a family history of diabetes, and a fasting glucose over 126. So a macrosomic infant, one that is larger in weight and size than would be expected, is one of the complications of gestational diabetes. So how is it treated? Diet, monitoring blood sugar levels, ketone monitoring, exercise, and fetal assessment. Sometimes, if none of these measures are effective, then administration of insulin may be necessary. It is important to note that most hypoglycemic oral agents, such as metformin, are not used during pregnancy because they can cross the placenta and possibly result in birth defects. therefore, insulin is often the drug of choice if the more conservative measures aren't effective in maintaining proper blood sugar control. So care of a patient during labor who has gestational diabetes. The patient may need an IV infusion of dextrose. And the reason for the dextrose is so that there's not a resultant hypoglycemic effect. Blood sugar levels are monitored regularly, and insulin will be given as per blood sugar readings. So care of the neonate in a mother who has gestational diabetes. This neonate is going to need to be monitored for hypoglycemia and respiratory distress. And because of the macrosomia, because of the large size, the infant may have sustained, the neonate may have sustained injury during the birth process. The blood glucose levels will be monitored closely for at least the first 24 hours after birth, and breastfeeding should be encouraged. The next condition that we're going to talk about is heart disease. Some of the manifestations that are particularly significant during pregnancy are increased levels of clotting factors. Remember, I mentioned in the last presentation that particularly in the second and third trimester, pregnant women are at risk for developing clots and at increased risk for thrombus. The woman can also be put into CHF if the heart can't handle the increased workload during pregnancy, and the fetus can suffer from reduced placental blood flow. Signs of CHF during pregnancy: cough, moist lung sounds, fatigue, difficulty breathing, orthopnea, edema, palpitations, and changes in the fetal heart rate. How is it treated? This patient will need to be treated both by an obstetrician and a cardiologist. The priority is limiting physical activity. Drug therapy may be incorporated, and classes of drugs that may be used would be beta blockers, anticoagulants, and diuretics. If we look at each of those classes, the beta blocker, what's it going to do? It's going to decrease the workload of the heart. It decreases blood pressure. It decreases heart rate. Anticoagulants, because the woman is in a hypercoagulable state, and diuretics to pull off that fluid, whether it's fluid in the lungs or fluid in the extremities in the form of edema. Vaginal birth is preferred as it carries less risk for infection and respiratory complications. Anemia, the reduced ability of the blood to carry oxygen to the cells. Anemia is going to be manifested by a low hemoglobin and hematocrit. There are 4 significant types of anemia that are found during pregnancy. Number 1 is an iron-deficiency anemia. This is one reason why iron is a significant component of the prenatal vitamin, because women can be at risk for iron-deficiency anemia. Remember that during pregnancy, the blood volume increases significantly because of the need to feed and nourish the fetus. Therefore, that can put the woman at risk for anemia, particularly in the form of iron deficiency. So to prevent it, iron supplements, like I mentioned. One key thing about iron supplements is that vitamin C can increase the absorption of the iron, so it's often recommended to take your iron supplement with some orange juice or some form of vitamin C. Iron should not be taken with milk or antacids because that can decrease the absorption. The calcium in the milk and antacids can decrease the absorption. Folic acid deficiency is a second type of anemia that can occur during pregnancy. If we contrast this to iron deficiency, iron deficiency is typically manifested by small red blood cells, whereas in folic acid deficiency, this is what we call a macrocytic anemia, where the red blood cells are larger in size. So how do we prevent this? Well, the folic acid supplement that we've talked about previously. The importance of the folic acid is, one, to help prevent neural tube defects, but also remember that folic acid is essential for normal growth and development of the fetus. So like I've stressed on a couple of different occasions, 400 micrograms is recommended of folic acid daily to give the woman adequate supply. If the woman is deficient, then typically a higher dose is recommended, a 1 milligram daily. There are two genetic disorders in terms of anemias. One is sickle cell disease. And these are not nutritional anemias, rather these are inherited. So in sickle cell anemia, the red blood cells have an odd sickle-like shape to them, and this sickling shape is not present necessarily all the time, but in times of stress or hypoxia, the cells can sickle and change shape, and this can cause blood flow to not flow properly, and these cells can be destroyed more rapidly as well. This is most common in the African American population. Pregnancy, because it is a stressful time on the body physically and emotionally for that matter, can predispose women to go into a sickle cell crisis. If that happens, significant red blood cell destruction can occur, and occlusion of vasculature can occur because of the sickling shape of the cells. Women who have a sickle cell trait or sickle cell disease need to be monitored regularly during the course of their prenatal care, and fetal evaluations will be focusing on fetal growth as well as placental function. Thalassemia is another genetic disorder, and there are several different types of thalassemia, alpha and beta. Some of the thalassemias are minor in that they don't cause many problems or issues at all, and sometimes these women just have a mild type of anemia, however, some thalassemias are more significant and require that the woman get transfusions. It is important to note that in thalassemia, it is not appropriate to give an iron supplement. It can cause iron overload. Sometimes thalassemia, because it is a microcytic anemia similar to iron deficiency, sometimes when folks see the numbers and the microcytic nature of the anemia, they automatically think it's related to iron deficiency and they recommend iron supplementation. But it is important to go ahead and do the studies to determine if it truly is iron deficiency or if it's thalassemia. What are some symptoms of the nutritional anemias? Fatigue, mucous membranes are pale, shortness of breath, pounding heart, rapid pulse. Iron deficiency anemia, like I mentioned, red blood cells are small, so they're what's called microcytic, and they're pale, so they're hypochromic. How do we prevent it? Like I mentioned, iron supplements, vitamin C is going to enhance absorption. Don't take the iron supplements with milk or antacids. You will want to continue the treatment for up to 3 months after the anemia has been corrected. Folic acid deficiency, like I mentioned as well, these are large immature red blood cells, so this is a macrocytic anemia. What can kind of predispose someone to this type of anemia? Well, anticonvulsants, oral contraceptives, sulfa drugs, alcohol can all decrease the absorption of folate, which can then predispose someone for this type of anemia. Remember, folate is essential for normal growth and development, and as everyone knows by now, 400 micrograms is the recommended dose. If someone has a deficiency, they may need up to a gram a day. If a woman has had previous children with neural tube defects, the dose will be even higher than a gram, usually 4 grams. So let's focus a little more about the sickle cell and the thalassemia. Sickle cell is an autosomal recessive disorder. It is the abnormal hemoglobin, like I mentioned. It causes the erythrocytes to become a distorted sickled shape during these times of crisis. And these abnormally shaped cells don't allow blood to flow smoothly, so therefore there can be occlusion of vasculature. Pregnancy, because it's a stressful time, can cause a crisis. Thalassemia, as I mentioned, it's a genetic issue. Folks with beta thalassemia tend to have fewer problems, and often the fetus is not affected. But it is important to assess the severity of the thalassemia because there are different gradations. And remember, iron supplements are not recommended because they can cause iron overload. And they're not going to help the anemia anyways because it's not an iron deficiency issue. Nursing care for anemias. Teach the woman about foods that are high in iron and or folic acid based on where their deficiency lies. Teach them how to take supplements. For example, don't take the iron with milk. You want to take iron with vitamin C. Warn them that when they're taking iron supplements, their stools will be dark colored, either dark green or black, and that is common. Women with sickle cell disease will require close monitoring, and they are taught to prevent dehydration or activities that can cause hypoxia because that can precipitate a crisis. They also want to avoid situations where they would be more likely to be exposed to infection. So the next thing we're going to talk about, the next topic we're going to talk about are infections that are complications during pregnancy. There's an acronym called TORCH that's used to describe infections that can be devastating to the fetus or the newborn. So TORCH stands for Toxoplasmosis, other, Rubella, Cytomegalovirus, and herpes. So we'll talk about each of those in the upcoming few slides. So remember, viruses, we don't really have any effective therapy for viruses. A viral process in most folks that are healthy and have robust immune systems, it runs its course. Usually 7, 10, 2 weeks, the virus will run its course. Immunizations can prevent some infections. However, an infant who is born to a woman who has an active viral infection, such as varicella, can be at significant risk because of the lack of robust immune system. Cytomegalovirus is an infection that can be widespread and can occur during childbearing years. It's often asymptomatic in the mother. That's one reason that it is such a challenging and potentially devastating virus. The infected infant, however, can have significant sequelae: mental retardation, seizures, blindness, deafness, dental abnormalities, and petechiae, which are those small little ruptured capillaries that you can see on the skin surface. There is no effective treatment known, so preventing, if at all possible, is the best measure. A therapeutic abortion may be offered if cytomegalovirus infection is discovered in early pregnancy. Rubella typically is a mild viral disease. It's one of the diseases that most everyone is immunized for when you get the MMR. So in most of us, if we were to get rubella, it would be mild. Some signs and symptoms would be a fever and a rash. However, the disease is devastating to a developing fetus. If a woman receives the rubella vaccine prior to pregnancy, she should not get pregnant for at least 1 month. This immunization, the MMR, is not given during pregnancy because it's a live vaccine. And if you remember in the last slideshow, I talked about the fact that live vaccines are never given to pregnant women. And if the MMR is given to a woman, she should endeavor not to get pregnant for at least a month. So what are the effects on the embryo or the fetus of rubella? Microencephaly, so small head size, mental retardation, congenital cataracts, deafness, cardiac effects, and intrauterine growth restriction. Herpesvirus, there are 2 types. If you remember back to last semester when we talked about herpes, there's type 1, which is likely to cause cold sores or fever blisters on the lips, and type 2 is typically the genital herpes. Remember, after someone has their initial infection with herpes, the virus is always present in the person's body. It can lie dormant for many months or years even, but it can get reactivated at any time. And often it gets reactivated in times of stress. The initial infection during the first half of pregnancy can cause a spontaneous abortion, intrauterine growth retardation, or preterm labor. Neonatal herpes can be localized or widespread and can produce a high mortality rate. Treatment, you want to avoid contact with the lesions. Mother and infant don't necessarily need to be isolated as long as direct contact with the lesions is avoided. Breastfeeding is possible as long as no lesions are present on the breast, because the way that it is spread is by contact with an active lesion. Hepatitis B is transmitted by body secretions, blood, saliva, vaginal secretions, semen, breast milk, and it can cross the placenta. The fetus can be infected transplacentally, so through the placenta, or by contact with blood or vaginal secretions during delivery. Upon delivery, the neonate should receive a single dose of the hepatitis B immune globulin. Remember, the immune globulin will provide immediate immunity for a short period of time, and then that should be followed by the hepatitis B vaccine. Who's at risk for hepatitis B? IV drug users, folks with multiple sexual partners, folks with repeated infections due to sexually transmitted infections, occupational exposure, so people that are exposed to blood products or needle sticks, hemodialysis patients, people who have received multiple blood transfusions or other blood products, any household contact with a hepatitis carrier or hemodialysis patient, and contact with patients arriving from other countries where there's a high incidence of the disease. HIV is the virus that causes AIDS, and it cripples the immune system. There's no known immunization, and there's no known curative treatment. There are significant advances in drug treatment, so now people are living much longer and having a much higher quality of life if they are HIV positive. How is it acquired? In one of 3 ways: sexual contact, parenteral or mucous membrane exposure to infected body fluids, or perinatal exposure. The infant can be infected through the placenta or through contact with infected maternal secretions during the birth process or through breast milk. So what is nursing care involved? Well, you want to educate your HIV positive women on the methods to reduce the transmission to the developing fetus or infant. Pregnant women with HIV/AIDS are more susceptible to infection, obviously because of the compromised immune system, and breastfeeding is absolutely contraindicated for mothers who are HIV positive. If you go back to the previous slide, that will make some sense, right? Because that is a way in which the infant can be infected. So now let's look at some non-viral infections. Toxoplasmosis, that's one of the infections that was part of the TORCH acronym. Toxoplasmosis is caused by a parasite, and typically it is transmitted through contact with cat feces or with raw meat, and it can be transmitted through the placenta. Usually a woman has mild symptoms. However, in a fetus, in a developing fetus, it can be quite devastating. And some of the possible effects can be low birth weight, enlarged liver and spleen, jaundice, anemia, inflammation of the eye, and neurological damage. Again, similar to cytomegalovirus, treatment is a therapeutic abortion. How to prevent it? You want to cook all your meat thoroughly. Wash hands and all kitchen surfaces after handling raw meat. Avoid uncooked eggs or unpasteurized milk. Wash fruits and veggies well. And avoid materials contaminated with cat feces. Group B strep infection. Those of you that are having your OB rotation, you'll probably learn quite a bit about Group B strep. It is the leading cause of perinatal infection, and it has a high mortality rate. So there's a lot of vigilance assessing for and treating for Group B strep. It is an organism that's found in the woman's rectum, vagina, cervix, throat, and skin. The risk of exposure to the infant is greater if the labor is long and the woman experiences premature rupture of membranes. Group B strep is a significant cause of maternal postpartum infection. Symptoms can be elevated temperature, rapid heart rate, abdominal distension, and it can be deadly in an infant. The treatment is with antibiotics, and penicillin is the drug of choice. Tuberculosis incidence is increasing in the U.S. and multi-drug resistant strains are increasing. So these resistant forms of TB are becoming much more harder to knock out. Mother can be tested via the PPD skin test. There's also a serum blood test for TB now called the QuantiFERON Gold. If it's positive, typically a chest x-ray is warranted and sputum samples will be necessary to assess for active infection. If active infection is suspected, this should get reported to the public health department because it is quite easily spread and because of the resistance of many of the strains. If the mother has active TB, the infant must be kept away from the mother until she's been cleared by the public health department. Sexually transmitted infections are typically transmitted via sexual intercourse. Some of the most common are syphilis, gonorrhea, chlamydia, trichomoniasis, and condylomata acuminata. A lot of times in a lot of practices, when a woman comes in for her initial prenatal screening, they will do a gonorrhea and chlamydia test. And usually do a PAP, depending on the providers. The gonorrhea and chlamydia are easily treated, and trichomoniasis can be evaluated via a PAP, and that can be treated as well. Syphilis is not as common. It can be assessed by a couple of different blood tests, a PRP and VDRL. Urinary tract infections. Pregnancy alters the self-cleaning action due to the pressure on the urinary structures. Also, it can prevent the bladder from emptying completely. And remember that retained urine becomes more alkaline and is a good environment for bacteria to proliferate. So some of the signs and symptoms would be burning with urination, urinary frequency, urinary urgency. Sometimes folks can develop a fever as well. Now, if UTIs aren't treated, they can evolve into pyelonephritis, which is a kidney infection. And these folks become quite systemically ill. They often present with a high fever and chills, flank pain, nausea, and vomiting. Environmental hazards during pregnancy, bioterrorism in the pregnant woman, three basic categories in terms of thinking about bioterrorism. Things such as smallpox or anthrax can be transmitted from person to person. Other forms of bioterrorism can be spread via food and water supply. Some examples could be brucellosis or Staphylococcus enterotoxin. And the third type can be spread via manufactured weapons that are used to spread disease. So, for example, hantavirus or tick-borne type of encephalitis. Substance abuse is also an environmental hazard. It's really important to question your patient about alcohol use, drug use and abuse, so that you can provide the most appropriate care to the pregnant woman and her infant. Remember that all illicit and recreational drugs have adverse effects both on the mom and the fetus. One of the probably most well-known types of syndromes that can result is fetal alcohol syndrome. So a single episode of consuming 2 alcoholic drinks can lead to some fetal brain death. Your book has an illustration of an infant born with fetal alcohol syndrome, and you can see the effects of the alcohol consumption on the patient. I think one of the important things to think about when you're dealing with these types of issues, substance abuse, drug abuse, is to ask the patient about these behaviors in as non-judgmental a way as possible. This is not a court, and you're not a judge. You're not going to impose any sort of penalty. You need to get this information so that you can provide the most appropriate care for the woman and the fetus. Trauma. Leading causes of traumatic death in pregnancy are automobile accidents, homicide, and suicide. And then it's always important to consider battery, domestic violence. So one piece of assessment when you're thinking about battery and domestic violence is looking at bruising in various states of healing. If someone confides that she's being abused, this information must be confidential. Her life may be in danger if her abuser learns that she's told anyone. She should be referred to a local shelter and given resources to help support her. But do remember that it is her decision whether or not she wants to leave the abuser. High-risk pregnancy. A high-risk pregnancy can have significant effects on the family unit because it can disrupt the usual roles of the family unit. Imagine if, let's say, the woman is suffering from gestational hypertension and has to be placed on bed rest and frequent monitoring, but yet she has 2 other small children at home and she usually is at home taking care of the kids. That could prevent or that could cause significant disruption in the roles. Also, it could cause financial difficulties. If, say, for example, the woman is the primary breadwinner and there's a high-risk pregnancy and she's not able to work. It also can cause delayed attachment to the infant. If for one reason or another the woman and the infant are separated after birth because of potential exposure issues, that can cause attachment issues. And also, if the woman is high risk, her vision of what her expected birth experience is could be changed because of the need for more closely monitoring and more invasive procedures. Thinking about the grieving process, allow the parents to remain together. Remember that everyone grieves in their own way and to support them. You know, if the infant were to pass away, or if there was fetal demise, offer the parents the opportunity to hold the infant if they want. A memento such as a footprint could be desirable. Provide the family with educational material and support groups, and offer them services such as chaplain or any sort of resources to address their cultural rituals. So one question I want to leave you guys with is I want you to think about the differences between placenta previa and abruptio placentae. And have a good grasp on how those two are different. What are the presentations that you would expect to see with each of those, and how would you differentiate them? And that'll do it for this presentation. Thanks for listening.